and gentlemen, we are here today in a Meet the Expert session at the Vicenza International course on AKI and CRRT. And we have the pleasure to interview my old friend, Lakhmir Chawla, who has been a good co-investigator in many studies we have done in the past. And I would like to ask him first to introduce himself and his current affiliations, and then probably to share the screen and start his presentation. That will be matter of discussion for today on new options in the therapy of sepsis. Lakhmir.
Yeah, thank you, Claudio. It's great to see everyone virtually. I miss being in Vicenza live. And for those of you who were there at the time, I miss having Prosecco at the podium, but that's a story for another time. My name is Lakhmir Chawla. I'm a professor of medicine, and I used to be at George Washington University Hospital, where Claudio and I had a common close friend, Juan Bosch. But now I'm at the University of California in San Diego, and I'm at the Veterans Affairs Hospital there. And I've also been working on some new hemoadsorbent technologies, and I'm looking forward to sharing with you some insights about a new one that's being used for pathogen suppression, but also for COVID-19.
So excellent. I will ask you to share the screen and present this different approach, which is based on extracorporeal pathogen adsorption in critically ill patients. And in the meantime, I would like to thank FRESENIUS Medical Care for sponsoring this event.
Absolutely. Okay, so I'd like to take you through a very new device that I don't think many of you have seen, and I hope there'll be some time for questions at the end. I think an important disclosure is that I'm currently the chair of the Scientific Advisory Board of Extracorporeal Medical and a board member, and I'll be talking about one of their devices in this talk as well. So I think one of the things that we've learned in this pandemic is an enormous amount about ARDS and lung disease that many of us may not have known so much about, but we all have become experts. And I think a question that will come up, and I think it's an obvious question, is why would removal of virus improve a lung disease? Because if you hook someone up to a filter and you remove the virus, that's almost certainly a good thing. But if you're dying of viral pneumonia, how does that help you? And I'm going to endeavor to talk about why pathogen removal is actually a really important thing. And I think the most important thing to recognize is that early in the pandemic, the assays for viremia were poor, and they've gotten much better. And this paper really takes us through an important notion, which is that viral load, and this is not the only paper, there are many papers now, but I think this is one of the best ones, is associated with critical illness. But the key issue here is viremia itself is causing problems. Now, what you're looking at here is viral load measures based on the N1 or N2 region of the virus. And what you see is if you're an outpatient and you have COVID, you have a little bit of measurable viremia, but not too much. If you're in the hospital, it goes up. But when you enter the ICU, this is where we see extremely high levels of viremia. So when you are very sick, your viral load is much higher. But I think here is the important issue. This is not just association. While yes, the virus levels are high because you're sicker, I think we could agree that that's a likely phenomenon. But the virus itself contributes to all of these very negative pathways: tissue damage, immunosuppression, activation, induction of Th17 immunity. This is what viremia does. Viremia is the pathogen in the blood that sets off this incredibly high level of inflammatory cascade. This is not dysregulated inflammation per se. This is inflammation due to a stimulus, and that stimulus is viremia. This is the body responding to a pathogen in the blood. Now, what's important is that these exact same step-ups in viral levels, as you can see, correspond precisely to the levels of IL-6 and CRP. So there's no surprise here, right? If you have high levels of virus, you're sicker, you also have higher levels of CRP, IL-6, and D-dimer and ferritin. So all the key factors that we see that delineate a very sick COVID patient map to levels of viremia. So, I think that there's some important types of observations. So we all know that cancer is a disease that starts locally, and then if you don't contain it, it breaks out. And it's always been my view that sepsis and these infections were dysregulated inflammation from the source. But I think COVID has altered my view a little bit, because we have this notion that you have culture negative sepsis, and therefore people are over responding to the initial source. But now that we can measure bacterial DNA and we have better assays, we find that if you use a BioFire assay or a T2 assay, culture negative sepsis is very uncommon. You almost always find a pathogen or lots of PAMPs and DAMPs from the pathogen in the blood. So this idea that they're culture negative and have dysregulated inflammation is probably wrong. It's the absence of evidence is not evidence of absence. And so what we believe happens in COVID, as I've shown you, when you have just lung disease, the viral levels are low and the virus is largely contained in the lung. But as you transition to positive pressure ventilation and translocation, you transition to viremia. And it's this group of patients who are going from a local disease to metastatic infection, in this case, COVID, this is also true of bacteremia, in whom we think entering the clinical space of intervention with pathogen removal is salutary. And you can see what these effects of viremia are. It's really quite broad: SIRS, coagulation activation, tissue damage, etc. So the virus itself contributes substantially to the negative outcome. So our treatment thesis is very simple. High levels of viremia are common. This does not happen in patients who are less sick, and the virus itself is a key modulator. So if these things are true, which they are, then removal of viremia is going to help mitigate, because this is a key activator. Now, if you look at what's available, there are many devices available, and I think this audience is sophisticated, which is not the case of all critical care audiences. But if you're coming to Claudio's meeting, you know something about extracorporeal filtration, you know something about the value of using an extracorporeal circuit to help the patient do better. Now, there are many filters that remove cytokines, and there is real value in that. There are filters that remove endotoxin. There's real value in that. But there's a different set of filters or adsorbers that specifically remove pathogen. And the three that are currently either in development or approved are the Aethlon Hemopurifier, the BOA device, and the Seraph 100. And I'll talk to you about each of these three. So the Aethlon Hemopurifier uses a galanthus agglutinin, and it holds on to mannose affiliation with lectins. And this hemopurifier has been shown to remove HIV, hepatitis C, and Ebola. And I think there's a recent case report. I haven't seen the publication, but there was a press release that this device may also remove SARS-CoV-2. This device is not yet approved in the US or Europe, but may have real potential. There's a new device being developed by a company called BOA Biomedical, which is based in the United States. This is entering a phase 1 study. This also uses an FC receptor, mannose-binding lectin. And we don't know if this device removes SARS-CoV-2, but it has a broad capacity to remove lots of other pathogens. I suspect it will be effective against SARS-CoV-2, but we haven't seen any hardline data. This is something which is in development and in phase 1. The device that I'm most familiar with is Seraph 100. This device is approved in the US and in Europe. And in Europe, it has a broad indication, which is pathogen reduction. And in the US, it is emergency use authorized for SARS-CoV-2 for COVID. And interestingly, this removes a very broad array of pathogens, bacteria, viruses, fungi, bacterial DNA, other PAMPs and DAMPs. And it does this by leveraging heparin sulfate as a surface. And what you're looking at here on the left is a picture of this hemoadsorber. It's about the size of a FRESENIUS F80, and it is something that you do hemoperfusion for. And as I mentioned before, this has a CE mark for pathogen removal and is approved in the US. And it offers a very large surface of heparin. So if you think of a FRESENIUS F80, it's about 2 meters squared of surface. This device, about the same size, gives you 40 meters squared of surface heparin. And I think one of the most important things that I'd like you to take away from this talk is that heparin is more than an anticoagulant. So if you have a patient who has a pulmonary embolus, you or a DVT, we've all given them heparin in our careers and we use it as an anticoagulant. But heparin is much more than that. Heparin is in your body. It lives in your extracellular tissues, and it lives very much on your endothelial glycocalyx. And it serves as a form of passive immunity. And what I think is really important for everyone to understand is that heparin as a surface is fundamentally different than heparin, the drug. And heparin as a surface, it turns out, is an incredibly effective way in which to remove pathogen. And the way we know this is that if you look at your endothelial glycocalyx, it is largely made up of heparan sulfate. And heparan sulfate is on the bottom right here, and this is heparin sulfate. And heparan sulfate and your endothelial glycocalyx has broad capacity to remove pathogen. So what this device does is leverages heparin sulfate and makes it a large surface. You can see that heparin sulfate and heparan sulfate are nearly identical in structure. And this is what allows this heparin surface to do what it does, which is to broadly remove pathogen. Now, I would love to tell you that, the scientists behind this discovered this is what heparin does, and they decided to put heparin on. But at the end of the day, there was discoveries that heparin did this, but all we were really doing was emulating something the body already does that we didn't understand that well. And basically, we think of this as endothelial glycocalyx replacement therapy. And it's impressive. I want you to look at the far right. This is the efficacy of pathogen removal for this broad array of nasty pathogens: MRSA, Klebsiella, E. coli, strep pneumonia, E. faecium, Acinetobacter baumannii, Serratia marcescens, Pseudomonas. It absolutely removes all of these with a very high degree of efficacy. And remember, it's not just about single pass removal. You're recirculating this many times in patients' blood. And unlike dialysis, when you're going after urea, which has got a total body water of 60% of your weight, you are just getting after the blood volume, which is a much smaller volume in which you need to go and get pathogen from. And it also removes a broad array of viruses and fungi. I think it's important to recognize, though, that even though it takes off HSV, Ebola, adenovirus, and CMV, the real thing we're interested in is removal of SARS-CoV-2. And it does remove SARS-CoV-2, and we have that with single pass and global data in patients. I think importantly, the one very nice thing about the Seraph 100 is that it does not remove antibiotics and other key drugs that patients require. And I think in the case of SARS-CoV-2 in particular, it does not remove remdesivir, which is the big drug that all of us have our patients on for obvious reasons. So, if we think about this as endothelial glycocalyx replacement therapy, we have a good concept of how this asset works. So it removes pathogen. That makes a lot of sense. It also can help remove microthrombosis and DIC, and we know that the glycocalyx helps remove oxygen-free radicals. So we are basically taking a device and trying to have it do what the glycocalyx already does. The problem, of course, is when you're very sick, is your glycocalyx breaks down and you lose that function. And if you think about the management of septic shock, rule number one is source control. If you still have viremia, you do not have source control. If you have bacteria growing in your blood despite adequate antibiotics, you do not have source control. So this is a strategy of pathogen reduction and pathogen suppression. When you get pathogen removal, pathogen suppression, you improve inflammation and coagulopathy because the source of the inflammation is removed. This device also removes DAMPs and PAMPs, specifically bacterial DNA, which is a very strong activator of TLR4. And if you decrease inflammation and you decrease the actual pathogen load and you get cytokines down, not surprisingly, you also get improvements in hemodynamic stability. And that's what we see clinically. Pathogen comes down, inflammation begins to improve, and that is then met with improvements in oxygenation and hemodynamic stability and decrease in vasopressors. So here are the data to show you that this actually removes SARS-CoV-2. This is a work from Jan Kilstein's group, and they beautifully show that at various initial dose levels, this device is effective at removing SARS-CoV-2. And there's some better data. This is not yet published, but this is a randomized controlled trial. And what you're looking at here is the N protein on the y-axis, this is time. And what you can see is in control patients, the viral load stays quite high through 24 hours and then begins to drop. Whereas you can see that in the Seraph group, there's rapid suppression and it stays suppressed after the initial treatment of 24 hours. So we were very heartened to see these data because it's very consistent with the mechanism of action of the device to remove this. And just to be clear, these are N protein levels of SARS-CoV-2. So this is not just imputation of this, this is actual data of removal of virus in patients. And how does one run this? Well, like I said, in a group as sophisticated as this, I don't need to tell you guys how to prime a circuit or set something up, but depending on what machine you have available, you can run it as straight hemoperfusion as depicted here. In the US, where we don't have machines as wide and varied and as good as you have in Europe, to be honest, we will often run it with a dialyzer. Even if the patient doesn't have AKI, in order to get the machine to play nicely with us, we have to put a dialyzer in. This is, of course, not the way we would like to do it, but in the US, this tends to happen. In the US, this runs largely on the next stage device. It does run on other devices as well, it's not limited. And in Europe, we're seeing this largely run on the Multifiltrate Pro for obvious reasons. This machine has enormous capacity to do basically whatever you want, whenever you want. But this can run on any machine that allows you to put the filter in. In my view, if you don't have a patient with AKI, it's better to run it without a dialyzer if you can. But if that's the only way you can do it, it's very doable. But I would prefer pure hemoperfusion from a device if possible. And this was the first case report that led to the emergency use authorization in the US. I'm not going to take you through this in nauseating detail because I think Claudia and I want to have a good discussion about the opportunity, the references here, but essentially this showed dramatic results that we continue to see. This is the indication for the US, which is basically if you have respiratory failure and COVID-19. But what I really want to spend the few remaining minutes on are these issues, which is if we look at the spectrum of patients who have COVID-19, we know for pre-hospital low flow oxygen, we have some therapies for that. Monoclonal antibodies and remdesivir helps here. And God forbid you're really, really sick, we can give you dexamethasone and some form of IL-6 blockade. But we really don't have anything for these people who are going from high flow oxygen, who are on the verge of being intubated or just intubated. And this is where we have been largely deploying this extracorporeal vial removal Seraph 100. It's this group of patients, patients on high flow oxygen who are on their way to being intubated. And when we do this, we get really outstanding results. We have shown very consistently that the survival is around 73%. This is across the pandemic, across different variants. And importantly, this device is variant agnostic, meaning that it doesn't matter which Greek letter is on the variant, this device removes it because of the nature of heparin and the way it binds the virus. And this is registry data. And what you see here is the patients who got the device had a survival of 73% versus 29%. This was a smallish registry, but I want to just show you these data. These are case control data run from Kevin Chung's group and the PURIFY group. And what you see here in a very well-conducted case control study is a massive survival benefit. I mean, this is not subtle, and the separation occurs early. And then if you even put in the slight imbalances that were in the trial into a multivariate analysis, what you see is that the Seraph effect is dramatic and holds up multivariate analysis and remains highly statistically significant. And it's important that you look at these numbers. You know, the survival in the registry was around 73%. That's what we see in this case control study. And we see that the patients who did not receive the Seraph have a survival around 30%, which is also what we saw in the registry, which was a different data set. So we're seeing very consistent signal across the enterprise. So in summary, we know that high levels of viremia are common in critically ill patients with COVID-19. And we know that the virus itself is a problem. So how do we get after this virus? How do we help the patient get better? Well, we're going to support them with their oxygenation. If they need renal replacement therapy, we will of course do that. But you have to get the source under control. You need pathogen suppression. And this device, like I said, is available in Europe. It is one of our distributors is FRESENIUS Medical. They've been an outstanding partner. And we know that this device can run very effectively on all their platforms. And it removes SARS-CoV-2. It has now been administered to over 700 patients with COVID-19 with really outstanding results. We're hopeful to see more use in Europe with data being published. Claudio has been helping us with this. And we believe this will really help us fill an important gap for critically ill patients with COVID-19. But this notion of pathogen removal and suppression, it really works across the enterprise of all diseases of infection where you still have pathogen in the blood despite best medical care. And with that, I will stop and look forward to discussing this with Claudio.
So thank you very much, Mink. And I think this is very, very interesting. And as usual, when you are in the forefront and the edge of new technologies, you always have many, many questions arising. So one of the questions that I have is, how would you identify the patient that requires this therapy?
Yeah, thank you, Claudio. That's a great question. And the way we guide our clinicians is a patient who is on high flow oxygen, who you are concerned is going to be intubated in the next 24 or 48 hours is really an ideal patient. So that patient, you know, it's 6 o'clock, 7:30 in the evening, you're getting ready to go home to have dinner with your family, and you look in on a patient you're worried about. And you look at them and you say, look, guys, watch this person very carefully. He has a high chance of being intubated by morning. That is the person. And it's not just about the oxygen levels, it's about that clinical bedside assessment. This person is getting into trouble. They look uncomfortable. That is the person where the risk benefit for an extracorporeal treatment makes the most sense. We all, I think, have lots of comfort in someone who's intubated, putting them on a device because we know how sick they are. But the key is to prevent them from being intubated. And so if you are early, appropriately, we have found that many of these patients end up not requiring intubation. It's very important, though, that you be skilled in getting a catheter in and being able to do a good therapy. And I say this with love and kindness to my American colleagues, but I think in Europe, you guys are better at this than lots of my colleagues because the nephrologists are not in the ICUs as much and don't come up to the wards and see these patients. So it's It's really important there be this close connection between the people who are capable in extracorporeal therapy and this indication. In the US, the nephrologists tend to get called late, and that's a real weakness in the system.
Yeah, I think I share this view, as you know, and we have discussed several times about sequential extracorporeal therapies, possibly adding also other systems to remove cytokines or other. And I think that you said it very clearly that you have to protect the organs and prevent aggravation and try to mitigate the effect of the presence of pathogens that are in the circulation. Maybe if any type of study, cohort, or even randomized trial is done, you can get afterwards retrospective data on the level of circulating pathogens, because this is not an immediate test you can do, of course. Now, practically speaking, what is the blood flow you recommend, and what is the anticoagulation strategy you recommend?
Yeah, so most people will use regional heparin. And as we know, our patients with SARS-CoV-2 can be hypercoagulable, usually a bolus of between 5 to 10,000 units with 500 to 1,000 units in the filter. It seems to work very well. We have had patients who are very hypercoagulable and have required either citrate or argatroban or bilvalirudin. And in general, I think the blood flow rate depends on the quality of your machine and frankly, the quality of the operator. I think we would like to see people run the device at 300 mLs per minute. It does work just fine at 150 or 200. The blood flow rate doesn't alter how effective the device works, but if you can increase the blood flow rate, you will reduce the pathogen more rapidly, which is what we want. So we have seen people use this on a multifiltrate Pro, of course, across FRESENIUS K and T machines. We've seen it used on Baxter devices. We've seen it used on the Next Stage device. So we know it can work on any device, but you need someone who knows the device and knows how to put on this filter and get it to work correctly. And the key, of course, as you point out very correctly, Claudio, is getting the blood flow rate to match the catheter and access that you have, and then getting the right anticoagulation. But all of these mechanisms would work. I would say that if the patient can tolerate heparin, heparin should be your first choice. If heparin is not working and citrate is not something you can do, I would say the second choice for non-citrated would be bilvalirudin or argatroban, whichever you feel more comfortable with as a treating team.
Now, speaking about dose and prescription, again, it's an extracorporeal therapy, and therefore you should deliver a certain dose according to a scheme. Would you recommend maybe lower blood flow and longer treatment, or would you recommend higher blood flow and shorter treatment? And in the end, how much is the blood processing that you recommend? For example, if you have a blood flow of 300 mL per minute and you assume that your blood volume is 4 liters, for example, you assume that in 13 minutes you get 1 blood volume cleared, and you might need to have several blood volume cleared. So what is your recommendation in this area?
Yeah, so we are recommending generally around 20 blood volumes to be cleared. So we tell people who are less sophisticated to do around 100 liters of processing. As you and I both strongly prefer, life should be weight-based, or at least volume of distribution-based, so you actually are thoughtful in your approach. So I would say that the 100 liters was based on an assumed blood volume of 5 liters. So generally speaking, 20x is the number. Okay. Now, the notion of intermittent versus continuous is a very profound question. And in my view, you would prefer, if you can technically achieve it, continuous pathogen suppression, as opposed to getting the pathogen down to close to nil and maybe giving it a chance to peek its ugly head up again and then reinitiating an inflammatory cascade. So yeah, if it is possible, yeah, I think you run it continuously.
Yeah, maybe you need a a quick and highly efficient shot at the beginning, and then running as much as continuous as you can. And it makes a lot of sense to add possibly also the filter in order to clear possible uremia retention products in case renal insufficiency will appear. Now, what are, just to conclude, the immediate endpoints that you would advise for a trial? In other words, how do you say, yes, the treatment is working?
Yes, I think the key factors we're looking at before survival, which is of course the easiest one, is if you deploy the device prior to intubation, how many patients end up being intubated? So I would say for that cohort of patients, the key metric would be ventilator-free days and prevention of ventilation. If you are on the ventilator and we put them on early, then what we are looking to see is, do they come off the ventilator faster? Similarly, ventilator-free days and time to extubation. The other group of patients in whom we're seeing lots of use is in single organ VV ECMO. So not a patient who has multi-system organ failure, but someone who is just got terrible lungs, they go on VV ECMO. And for them, I think the corollary is ECMO-free days, time to decannulation, ICU survival, ICU discharge. And these are the key metrics we're looking at, not just because they're short of survival and perhaps we have more events, but these are patient-centered. None of us want to be on ECMO, and God forbid you are on ECMO, the sooner you get off, the better your life is going to be. Same with being on a ventilator. So we are confident these are patient-centered outcomes that you can track in a smaller sample to see if you're doing it right.
Yeah, I could not agree more. Very, very last question. How would you confute the statement of someone, of the usual skeptical people that say, oh, this patient would never go into intubation anyway?
Yeah, I think that the clinical course would say that that's probably not true. Most of these patients get intubated, they get into trouble. But that's why you do the studies, to demonstrate that these people often get intubated, and we would demonstrate that with real data. I think the bigger question is something, Claudio, that you and I and our friends believe, is that there's a group of people who say, yeah, well, you need to show me the data first before I will do it. And I appreciate that, and I'm not saying that's wrong. But if you're going to wait to do anything and everything, then you are going to be the least effective doctor and nurse and team out there. Particularly in a pandemic, but you and I had this belief before the pandemic, you have to try. Good centers, great centers, they try. They take safe tools, they have to be safe first, and they apply them, whether it's fluid overload and CRRT, and not doing intermittent hemo on a patient who is on high doses of noradrenaline. If you want to get the best results, you have to take the tools you have and apply them skillfully early. Absolutely. Not everyone has this belief. Yeah. More people who come to this meeting have this belief. And if you have this belief, these tools, not just this one, but others, are going to help you get better results.
We were lucky to receive a few samples that we were ready to use. We were even luckier than in the moment we received our incidence of patients with COVID-19 in the ICU dropped to 0. So
well, that's good.
But we are ready to go for this. And just to anticipate something to our audience, you, I, John Kellum, and others are going to write indeed our position statement on the idea that we need to identify the patient, to assess the risk of this patient, and as you say, to try to respond to specific clinical needs in the moment they have those needs. So different extracorporeal therapies may be needed in different moments, and this is probably the basis of what we have advocated in the past as sequential extracorporeal therapy. Thank you so much for answering my question, for presenting your talk, and in 2022, I hope to see you again in person in Vicenza, Italy.
I look forward to it, and my best to everyone. Very good to see you, Claudio.